If you welcome Dr. Sarah Burke.
Thanks very much, Kevin, and thanks to Ethna and Caroline for inviting me here today. I'm never sure if it's better or worse if the Minister stays or goes. I was all ready for the Minister staying, but anyway, I'll talk as if she's still in the room and maybe some of it will drip feed back to her. I'm going to talk to you for the next 25, 30 minutes. Maybe after about 20 minutes, give me a nod, will you, so that I keep to time, because I'm aware we're a bit behind schedule already. I'm going to talk you through really it's drawing on work I did, which I was funded to do by the Mary Raftery Journalism Fund. And many of you will be familiar with the journalist Mary Raftery, whose probably most famous series is called Behind the Walls, which was exposing the extent of incarceration in asylums in Ireland in the 1960s and bringing that up to the 2000s. And it's a piece of work I completed during the summer for Drive Time Radio. So it's a piece of work I did with my journalism hat on rather than my academic hat on. And for some reason, the organiser of the event invited Steve and I to speak in the same panel. And Steve was my PhD supervisor and is now my boss. And I'm not sure whether I'm more nervous talking in front of the Minister or my boss. But anyway, so it's with my journalistic hat on, but it's also informed by some of the work that Steve and I are doing together about what are the impacts of the cuts on the health system. And briefly, what I'm going to go through is revisit some of the Programme for Government commitments in relation to mental health. Some of the stuff I came across around the differences between psychiatric, and this is hospital care, between public and private. I'll just briefly go through that. And then really it's my assessment or an overview of the current state of adult mental health services, and very much focused on adults and community services, although lots of that is hospital based. So it's not specific at all to mental health or psychiatric nursing, but obviously as the largest staff group within those services, you play a key and important role. And Kevin, if you agreed with me, if all of you agreed with me every week on the radio, I'd definitely be doing something wrong rather than right. So hopefully we can have some discussion, good discussion at the end of it. I don't know how many of you are as Anuraki as me, but go back to the 2011 Programme for Government, but it is actually worth going back to, and it opens with, on the 7th of March 2011, the people of Ireland went into the polling booths and they struck a democratic revolution with the tips of their pens. There's, I think, 80 pages of commitments, some much more radical than others. There's 87, over about 20 pages, 87 commitments in relation to the health services. And they are indeed radical commitments in relation to the health service, promising about a one-tier system where access is based on need, not ability to pay, transferring from our current tax system to universal health insurance, free GP care by 2015, like very, very radical commitments in relation to health. Specifically, there's a whole range as well in relation to mental health, and I've just put some of them up here, but it was very much about endorsing and implementing a vision for change. So all that was committed to within Vision for Change was sort of re-endorsed in the Programme for Government. It also talked about mental health services becoming part of this standard package of this elusive universal health insurance that's promised, about having this national directorate, including a national directorate for mental health, which was something that's called for a long time and is now in place since July of this year. The implementation of a suicide prevention strategy, closing the old psychiatric institutions. It talks about psychologists and counsellors being made available in primary care, and there was just a small step to that begun this summer. A cross-departmental group in relation to mental health, I'm not sure that's happened. No children in adult psychiatric wards. Again, there's been continuous progress on this, but I think last year there was still about 100 children obviously placed extremely inappropriately on adult wards, but it has continued to go down. This review of the Mental Health Act, and we have the bill at the present. And I think critically for me, and this is the bit I wish the Minister was here for, it committed to 35 extra million a year and moving towards the Vision for Change commitment of having the mental health budget of 8.4% of the overall health budget. In terms of what's happened, and obviously this is a very quick and dirty overview, but there has been this very successful shift out of the old asylums and the institutions into the community or into hospitals that are in communities. So there's this huge reduction, 86% reduction, I think, from the 1960s to the most recent HRB census of admissions to acute inpatient units. And there's now about 2,500 people today in any one of those acute units and about 1,500 in the community. So a huge reduction. And critically, as the Minister pointed out, about people spending 40 years in one institution in St. Senans, she was referring to, there's just 289 who've been in any of those acute units for more than a year. So there has been this pretty successful shift out of institutions, and most out of what people talked about as those old asylums. And yet, if you look at the Inspector of Mental Health Services reports, annual reports, and his regular inspections, he would find continuously a lot of, or some of the hospital units are still not compliant with all the areas that they're meant to. Again, there are improvements, but there's also some disimprovements in some of them, and I'll come back to that. And there has been this huge emphasis on transferring care to the community. And also that most mental health care is actually dealt with at a primary care or GP level. And one of the things, actually, I was just talking to Martin Rogan at the end of lunch, I was saying, and I've worked in or around the health service for nearly 20 years now, but it was really only this summer when I got to do this Mary Raftery work in the mental health services, did it actually dawn on me that the adult mental health services, say the adult community mental health services, are really only for people with enduring or acute mental illness or difficulties, that they're not actually there for the 10% or the 90% of the population, most of whom of us will experience some crisis at some stage of our lives and need some mental health support. And I think if I don't know that, the general population doesn't understand that that's what adult community mental health services are there for. So even though most, and GPs would say 35% of people presenting to them present with a primary, not diagnosis, but it's a mental health issue, and yet not 1% of the GP budget is spent on mental health. Just briefly, the budget, and you don't have to pay much attention to these figures, but basically what it shows is that between 2008 and 2013, over $250 million has been taken out of the health budget. And that's a greater proportion that has been taken out of the overall health budget. And what we see in the bottom, the percentages there, is that the percentage of the budget allocated to mental health has declined, not increased. So therefore, we're much further away from that elusive 8.4% identified in Vision for Change, or even the one that was reiterated again in the Programme for Government Commitments. And again, you can understand in the current environment that the mental health budget has declined, but why has it declined disproportionately more than the rest of the health budget, particularly when we know that the economic crisis means that there are more people in distress looking for care and services. This is just trying to synopsize this extra money every year. Don't bother looking at the slide, I'll summarize it for you. Basically, very little, if any, of that extra 35 million has been delivered year on year. For 2007, 2008, I think Tim O'Malley was the minister then, swore it was there, and then eventually it came out through Freedom of Information requests that it was used to shore up overspend in medical cards. They didn't even pretend to give you new money between 2009 and 2011 because they just didn't have it. It was allocated under Kathleen Lynch's as minister in 2012, but not spent. And this whole gaming, what I see as gaming of budgets, so they were hiring the staff, but none of them were in place till the end, till December, and therefore they didn't kick in into the budget the following year. So therefore this year, the minister claims that there's this 70 million because there's 35 million and 35 million. But actually, when you look at the numbers, because of cuts to the overall health budget, it's actually a 22 million increase. And again, this year, the minister's commitments of 35 million falling well short, with 20 million allocated to mental health. And actually, what will be really interesting is to see how far the overall budget declines, to see whether that 20 million makes any difference or not. In terms of staff, there's about So yes, there have been more staff hired, particularly in sort of therapies areas, talking and therapy services, but there's fewer staff, 900 fewer staff now than there was in 2009 in the mental health services, and that's because more people are leaving under those incentivised retirement schemes than are being brought in. And again, this constant gaming of staff. In one of the radio programmes, I talked to Clonmara services, and they said they were promised 7 staff, but actually only 1.5 of them materialised, and both of them were on short-term contracts, so they weren't really new long-term permanent staff in place. And yet, even with this huge pull out of staff in the services that I'm sure you can feel day in, day out, the HSE is still over 1,500 over. It still has 1,500 too many, according to the Troika, staff in place. And yet, I think increasingly there's an acknowledgement at senior HSE level that there's no way they can get to year end and take those additional 1,600 out of the system. And the figures that I showed you around the budget, they were completed by 2 colleagues in Trinity, Julia Fido and Charles Normand, who pulled together these figures. But what they also showed was that there was a total failure to transfer both budgets and staff during 2007 to 2012 from hospitals to the community. So while there's this policy and rhetoric about services in the community, if you follow the budgets and follow the staff, that not 1% of a transfer happened during that time. This is just briefly this look at the difference between public and private psychiatric hospitals. And what the Inspector for Mental Hospitals report shows on the public facilities is that they are varied facilities. Some of them have been modernised and very good. Some are still in quite old, run-down buildings where it's not really appropriate for people to be, and still some not compliant with the very strict regulations that the inspector has. They are available nationally. The shift is having a ward in an ordinary hospital rather than having these stigmatised asylums out on their own in the community. Vast majority of patients in hospital acute psychiatric wards are public patients, and a really very different population to those who use the private psychiatric hospitals, with over 50% from unskilled manual classes, but also poorer, sicker patients in the acute public hospitals, and also dealing with more acute illnesses in the public hospitals. Interestingly, much shorter lengths of stay in the public hospitals, and also good links to the community services. And the incentive really is to be at home and in the community rather than in the hospital. And really quite sort of the opposite, like in the psychiatric hospitals, very much largely Dublin-based. Some of you might work in them. They're much nicer places to be. The private facilities, they generally have, they're nicer facilities. And yet, if you look at who goes to them, between 80 and 98%, 80% is St. John of God's, 98% is St. Pat's, are privately insured. Much fewer people from lower income groups, much fewer people with the more acute illnesses like schizophrenia, but also much higher levels of treatment for treatments which are like alcohol treatment, which is now considered best practice in the community rather than in the hospital. Much longer lengths of stay, higher uses of ECT, and virtually no links to community services. And the incentive is to be in hospital. And I was covering health insurance stuff a couple of weeks ago, and I was just looking again, even at the most basic, the cheapest plans still cover you for 180 days in a private psychiatric hospital, right? So there's this real incentive if you're privately covered to be in hospital, and if you're publicly covered not to be in hospital. And I left the public-private stuff thinking if I had an enduring, and I interviewed people who were using these services, an enduring mental illness, you're much better off in the public system because you have those community services ad hoc as they may be. So, what's happened to the mental health services during this time? Again, it's hard to make hard and fast judgments because, for example, the HSE has begun to collect good information on the makeup of the child and adolescent mental health teams. But they're beginning to collect that information on adult teams, but it's not publicly available yet and it's not complete. But from the figures that I saw and the people I talked to, the community mental health teams are at, and this is an optimistic view on it, at about 40% of what the staffing was envisaged in a vision for change. And there is this huge postcode lottery, and again, I'm sure you're much more familiar with this than I am, but you can live on one side of the street and your local public system, community services, is well resourced with OTs and counsellors, social workers, speech and language therapists, and you could live on the opposite side of the road and hardly have any of those services. So just this potluck with where you live and what catchment area you're in. And associated with that, this complexity of having a continuity of care, because if you don't have staff in place, it's very hard to provide that ongoing care in the community. And also this drag, this focus, which happens all the time in the Irish health system, this drag back into the acute hospital system. And that's because under the mental health legislation, the staffing in the acute units has to be at certain levels. So with reduced staffing all round, if there's only a pot of one staff for a particular catchment area, those community, particularly the nurses, get dragged back into the acute unit for adequate staffing levels, and it's the community services that suffer most. A big issue that came up and was brought up or shown to me by the mental health reform, who had done consultations around the countries, was this absence of crisis services. And again, I spoke to users of mental health services, and they said, look, my crisis very rarely happens Monday to Friday, 9 to 5. It invariably happens on a Friday evening or Saturday morning, but there's none of those support services there. And one of the things that really struck me most during doing this work over the summer, and by the end of it, I had about 45,000 pages of research and documents on the Irish mental health services since 2008. Like, it must be the most over-researched community in the country, right? People who use, particularly inpatient acute psychiatric units, right? And yet, no assessment of outcomes. Nobody's saying, how did you feel after you left this service? Or can you go to work? Or can you get up in the morning? Or what other supports do you need? And so no way of quantifying whether the services they are getting, or maybe not getting, are useful. And equally with the adult mental health services, very hard to quantify, or impossible at the moment to quantify, how many people come into the service, how many services they get, and where they go at the end of it. This is the most recent, so the 2012 report from the Inspector of Mental Health Services. And he talks about how the services are stagnant and perhaps slipped backwards in 2012, how it was a very difficult year for services, particularly for staff trying to maintain high quality care because of the squeezed resources and the general uncertainty. So this would paint a very, I have huge respect for the Minister's leadership and commitment and support in this area. But if you talk to people on the ground, and if you read the Inspector of Mental Health Services, it paints a very different picture to the one that the Minister paints. And he says, Ireland's mentally ill can be reasonably assured of a reasonably satisfactory standard of treatment in a caring, compassionate environment. And if I broke my leg and they told me I could go to Vincent's Hospital and I could be reasonably assured of a reasonably satisfactory standard of treatment, but they'd be really nice to me, they'd be really caring, but they may or may not fix your hip, I'd be very worried. And yet this seems to be an acceptable standard within mental health services. He talks about it being much more medicalised than what was envisaged in a vision for change, this slowdown in the growth of the mental health teams, and that the teams, for the most part, are incomplete. I did quite a bit of trying to talk to people who were users of the services. And again, these are people who have enduring and chronic mental ill health, so that 10% of the population. And they were saying how this absence of services denies them the ability to have what a vision for change envisage, so that they're meant to be central to their care, but without the supports and the services, that's not necessarily possible. This over-reliance of medication came up again and again, and people being sort of left to look after themselves or their families to do a lot of the caring. I spoke to a group of service users in Rathmines, and they spoke about, each and every one of them spoke about having their script renewed once every 6 months and having to go to an outpatient appointment with the psychiatrist, and feeling that they were over-medicated or the dose was too high and looking for a medication review. And every time they went in, they saw a new junior doctor who said, I can't possibly review your medication because I don't know you and I've never met you before and I don't know your history. And they were sent back out to the community with that same script, with this dosage that they perceived was higher. And just as I started the series on Drive Time, Ivor Brown's latest book came out, and he spoke very eloquently, as he does, and he spoke about how, yes, we had got rid of the asylums, but medications were the new institutions of the community. So we weren't locking people behind walls anymore, but we were, in a way, the drugs were these new walls in the community. And we do know that this absence of prevention and support leads to unnecessary hospitalizations and acute episodes. And again, the Minister is right. There are great examples of good practice where we see the opposite around the country, where with really good support from people, from nurses and OTs, in counselling in the community, you can prevent relapses or unnecessary hospitalizations. But when those services don't exist, then that's denied to people. This is the last report of the Independent Monitoring Group of A Vision for Change, because they were abolished by the government and never re-established, which is sort of a handy thing to do with an independent monitoring group. And their last report very much spoke about the impact of the embargo and moratorium, saying that it's impossible to plan for service delivery, put that people power, I hate that word, manpower, people power strategy in place, and particular shortages across the board of nursing, psychology, occupational therapy, social work, junior hospital doctors, which make it extremely difficult to populate mental health teams. I'm nearly there. You'd be glad to hear. The crisis, I think, is being used. I think it was happening anyway. Don't waste a good crisis, or whatever Ram Emanuel said. But they were reconfiguring, Martin Rogan and co were busy reconfiguring mental health services. But I think the economic crisis has allowed, and the Haddington Road, Croke Park 2 and Haddington Road has allowed that to shift a bit quicker. And staff are expected to move and travel more and change their places of work. Again, the most recent report from the Inspector of Mental Health Services talks about staff are under enormous pressure and are themselves at risk of mental ill health. And I just thought, God, if the Inspector of Mental Health Services is saying the reduction in staffing and under-resourcing is putting the staff and the services at risk, their own mental health at risk, then that's a very worrying notion indeed. A couple of weeks ago, I spoke at the Directors of Nursing, General Nursing Conference in Kilkenny, and Tony O'Brien spoke at that same conference, and he talked about poor care costing more. And indeed, the Minister, in the light of the HICWA report into Savita Halappanavar, has been out in this as well. And yet, we don't know about the impact of less staff and what that has on quality of care. And we don't know that because we don't measure the volume of care we currently provide, but we certainly don't measure the outcome of care. And I think there are very worrying indicators that if there's fewer people trying to provide more care to more people in greater need, then that quality of care does or can suffer. And this is what I've talked about already. There is this absence of support for people the 90% of the population, not the 10% with the inclusion during mental illness, but the rest of the population that is virtually non-existent. And also what we're seeing is a slowing down of the progress that has been made in terms of moving out of institutions, but also a lack of the progress on developing these community mental health teams. And I think at the crux of this is the denial of the right to recover or to live independent lives and a good quality of life. And the Minister spoke really eloquently about everybody having a life worth living. But if we don't have those sort of more gentle supports for the 90% of the population who have some sort of crisis or support needs, and particularly if we don't have those support services there for the 10% with the enduring or acute mental illness, then that's what we're doing every day. We're denying these people the right to live a life worth living. I think what's happened in the last week, and maybe this came up this morning at the conference in terms of the Cork GAA hurler Conor Cusack coming out and that incredibly powerful blog he wrote, an interview he did with Miriam on Primetime, and then John Murray the radio presenter yesterday morning going on air saying, I've just taken 6 months off work because of depression. I actually do think we're at a watershed in terms of stigma and mental health in Ireland. But I had this conversation with Orla Barry last Christmas. I thought the death by suicide of Shane McEntee was going to kickstart that, this political and public awareness, just that too many people are living in distress and too many people are dying. And I think it is interesting that it didn't happen around Christmas time, but it does seem to be happening at the moment, coming from different sources. But unless the minister can be as committed as she wants to be, but unless she delivers in terms of the budget and staffing and support services, then the stigma, we have to shift the stigma, but in order for that to translate into better services, into better care, and that's what nurses do best, then you need those budgets and you need that staffing. And let's see what's in the service plan in 2014. Okay, I'll leave it there, I think.
Leave you with Julie, who will give a personal perspective.
Thanks. Thank you. I changed the title a bit because I thought this. I read the document, the kind of the vision for change, kind of nursing vision for change, and thought actually I really want to think about what good looks like then for mental health nurses if we're to put that in place. Having done that, though, I've now listened to the last few papers and thought, but I really want to answer those questions. I really want to talk about how we as nurses could respond to this economic challenge and what the workforce needs to look like. But maybe that'll save for the panel. And I suppose I want to really just this is the last plenary paper for the day, and it won't take too long. I just want to summarise really what I think all of the messages we've had around recovery mean for us as a nursing profession. Can I just ask you, how many people here are nurses? Yeah, good. So I am talking largely to nurses. Can I ask you how many people here bring their own experience of living with mental health problems as either a service user or a family member? We've got a good amount of that, because you see, I think that's where the workforce is going to start to be driven from, is actually from people bringing that experience into their practice. And there is, an increasingly strong economic case for that, isn't there? Peer support, mutual, reciprocal support is really demonstrably, it improves outcomes. And I don't think we should be surprised about that, because people bring so much expertise from their own experience. But we want to think about what that means for nurses. I suppose what I'm going to be talking about, how, recovery is a simple concept. It is sort of motherhood and apple pie and what's new about it. But it's very challenging to get those kind of values into practice, which has grown up in a very different way. It's got a long history of us investing in having expertise, having superior expertise and power, and knowing what's best for the people we care for. So it's tricky, even if it is very commonsensical. I think that we do have an enormously important contribution to make in supporting people's recovery, but it means we have to change the way we do things. And it means that we have to really start to listen to what people's priorities, preferences, wishes are. And we have to work in partnership with them to help them to achieve their goals. Very much in the ways that were being spoken about by Agnes, by Alison, and by Jackie this morning. I'm talking here around a sort of co-production, around collaborative working, shared decision-making, joint planning, not about either privileging service users' expertise, families' expertise, or professionals' expertise, but really saying, what are we bringing to the table, and how can we each bring what we've got to find a solution and a way forward? I think that if we can kind of bring these recovery-focused philosophies, if we can create this context in which recovery can flourish, if we can help people to recognise that they do have the skills, the capacity to take more responsibility for their own well-being, if they feel safe and confident in doing that, then that actually reduces the demand and the burden on services and on professionals, and it enhances the lives of the people we work with. So this is all very consistent with the kind of economical challenges. You'd have seen this slide if you've listened to me ever before, just to remind ourselves that recovery is no single thing. It's not something we can define easily. It means different things to different people. And that's what we have to stick with when we're thinking, so what does it mean for nursing? It doesn't mean any single thing in the way that we behave. It just means that we have to listen to what people themselves want from us. It doesn't mean rejecting wholeheartedly a biomedical model. It doesn't mean rejecting wholeheartedly a social model. It means listening to people. This is just a group of people on an acute inpatient unit asked what recovery meant to them. And you can see here, that they're saying very different things. Just believing that I could possibly be happy, doing things with friends, when you stop punishing yourself, when life stops hurting, when you think that you could perhaps have a good time, when you think you're doing okay, when you can help someone else, and when you feel satisfied and comfortable. So those are the kinds of things that we're talking about here. Recovery can't be defined simply in one way. It's about people finding ways of living the lives they want to live. And we have to think then, people say, we've been doing this all along. I don't know why you're going on at us. And I just want us to reflect for a minute on then just to what extent are we already doing recovery, and to what extent do we need to think about what it means for us? Just ask yourself, are we focusing our attention as nurses on symptoms and problems? I think generally, I have to say, in my experience, that's where we focus our attention. In your practice, are you routinely helping people and supporting people and educating people to understand and manage their symptoms and to manage their own treatment, to manage their own lives? Are you already supporting people to